It's August 23, 2024. This is the Room Now podcast. Hi, I'm Jack Cush with RoomNow.com. This week on the podcast, the challenge of lupus nephritis, perplexing skin problems that rooms have to deal with. Yeah, you don't know jack about TIC2, and I want to talk about the value or wasted time with family history. Oh, that's a good one at the end. We're going to begin with GPA and the role of prophylaxis with Bactrim, Septra, trimethoprim, sulfamethoxazole, TMP, SMX. This is a study, I think we talked about this at ACR in 2023, finally hits the publication this past month. 919 patients with GPA who receive or don't receive prophylaxis. I think the number was 31% received prophylaxis with TMP, SMX. And while you're doing the TMP SMX prophylaxis for the purpose of preventing PJP, the main readouts on this were overall less outpatient infections, like 20% less, significant. Overall less serious infectious event rates, and that's like 50% less, and that also was significant. And yeah, there were less PJP events. There were 13 PJP infections. And they were all occurred in the people who did not receive TMP SMX prophylaxis. So I think these numbers are big because think about it. These are GPA patients. They're getting a lot of immunosuppression. They're getting a lot of steroids. They have highly inflammatory disease. And infection is a big problem, and a big problem as far as mortality, morbidity. And that's all above and beyond the risk of pneumocystis urovecii infections. So these numbers and this practice are really encouraging. I want to talk about lupus because we talked about that before. Open with lupus, it's always a good idea. A review of many different sources looked at preconception predictors of adverse pregnancy outcomes in lupus. And it turns out it's everything that you probably know, but I think it bears repeating. Lupus activity, and this is for preconception evidence of these factors. It's bad enough when they occur during pregnancy, but if at preconception, you shouldn't be getting pregnant. That's lupus activity as measured by SLEDAI, lupus nephritis, chronic hypertension, and evidence of the antiphospholipid syndrome. These are all good predictors of adverse pregnancy outcomes. A meta-analysis of patients with lupus nephritis and their starting dose looked at what happens based on starting dose and what are the predictors. So this is 50 studies that were in the meta-analysis, over 3,000 lupus nephritis patients, and they looked at two starting doses, 25 milligrams as a starting dose of prednisone versus 60 milligrams. And not surprisingly, a higher starting dose of 60 milligrams was associated with a higher rate of complete response, 35% for 60 milligrams versus 20% for 25 milligrams. But if you go with the higher dose, the higher starting dose of prednisone, you also increase your odds of serious infectious events, where it went from 3.2% at 25 to 12% at 60 milligrams, and death, the worst outcome. A 0.2% risk at 25 milligram starting dose versus a 2.7% risk. So steroids, wonderful, but then there's always a heavy downside. And it gets heavier as you go higher. You got to consider, you got to weigh the pluses and minuses when you're making those really tough decisions. I don't know how you weigh serologies in staging your patients and staging risk, but there was a nice systematic review of anti-Smith antibodies or SM antibodies, 17 studies. Overall, they showed that had a really high specificity, and you know that. It's maybe only second to double-stranded DNA with a 90% specificity. It's not seen in the majority. In fact, it's seen in the minority of patients. Interestingly, it's primarily seen or mostly seen in African-American patients. But what they showed in here that I wasn't probably too clear about was that Smith antibodies by themselves are associated with higher degrees of lupus activity. And that even you can see in some patients with the highest degree of lupus activity, they had higher titers of SM antibodies. However, the presence of SM antibodies did not predict the risk of or presence of lupus nephritis. Interesting. Lastly, not lastly, but next interesting is a skin disorder. Actually, more than a skin disorder, Vexus, as you know, described a few years ago as a unique somatic mutation leading to disorders that we confuse with a number of different things and look like Behçet's and other things. This is a cohort of 112 Vexus patients that were studied, and they specifically looked at skin involvement. And it turns out that skin involvement was a common phenomenon seen in 83% of patients. And it was tended to be seen early on in most of those patients. When you looked at the pathology when that was available in about half the patients, they were either leukocytoclastic vasculitis in a third, neutrophilic dermatosis in a third, and perivascular dermatitis in 30%. I think the main point of this paper was, well, one, the skin manifestations responded really well to steroids, like over 90%, 92% responses to these skin findings, right? But they did show that there were specific somatic mutations that were associated with different skin findings. So specifically, the pMet41 leucine variant had a higher association with what looked like a Sweets syndrome kind of dermatitis. That was seen in 82% of people with that leucine variant. If you had a valine variant, a pMet41 valine variant, that had a higher risk of other manifestations, including more than half the patients with vasculitis-like lesions. So again, I think we're learning more about Vexus. We're learning more about treatment. Interestingly, in this report, the use of an IL-1 inhibitor was associated with really bad IL-1 inhibitor injection site reactions and even evidence of, I think, ulcerative or necrotic lesions. So, but I think that we need more research on Vexus. Again, I think the risk was something like 1 in 4,000 men over the age of 50 may have this variant. I haven't seen it yet, but then again, I haven't been looking for it. Alopecia areata, alopecia universalis, the major advance in recent years has been the use of JAK inhibitors. You know, the original research started with baricitinib. Baricitinib was the first to get approved, and now a number of the other JAKs are falling in line, either with research or soon FDA approval for this. The real question is, as you know, JAK inhibitors do response to them is really pretty brisk, right, for things that we use it for. Is it that way for this hair loss? When I've used it, and I've used some baricitinib, I've probably used more tofacitinib, and I was using them off-label before they were approved. Kind of a slow response, but you definitely start to see skin hair growth within a month and visible hair that the patient was proud of within 12 weeks. The question is, if you have to stop a JAK inhibitor in someone who has alopecia areata or universalis, when is it that they start to lose hair again? And this happened with me in a few women. I can remember one really well where she had to stop, wanted to stop. She fully had totally no hair, nowhere, no eyebrows, no underarm hair, no pubic hair, nothing. And on tofacitinib, she got all her hair back. It was just miraculous. But then she got married. Then she wanted to have a baby. And then she got pregnant. And the question is, what do you do? Well, she stopped her JAK inhibitor. And guess what? Lost all her hair right quick. Well, there was a research study that was reported this week, a sub-study of the registration trial called Brave 1. And in that study, 80% of the people who stopped their baricitinib had loss of hair. And that was compared to 8% loss of hair or worsening in those who continued the baricitinib. So clearly a big time loss. So I think it's important that you count. And it does, by the way, happen pretty quick, like within weeks. You start to lose the hair. The other important part of this sub-study was that when you if they get treated with a JAK inhibitor and then you stop and then they start to lose all their hair again or they go bald again, how can you regain the response? And yes, the vast majority of people did regain response. And I think that's kind of cool and really good information. While we're on the topic of skin disorders, I don't know about you, but I have seen a fair number of patients with hidradenitis suppurativa where I'm largely managing the skin disease, although they may or may not have musculoskeletal features that may accompany that. And what I did not know, because I don't think I'm as well trained in HS, is that tobacco use and smoking is a risk factor for developing hidradenitis suppurativa. In this particular study that I pointed out this week from Korea, fairly large cohort study, looked at 6 million people in the population. 3,700 had hidradenitis suppurativa, and they had data on their smoking history. And they basically found, compared to people who continued to smoke, there was a significantly less risk of incident hidradenitis suppurativa in those who quit smoking. So if you were a smoker and you quit, you actually lowered your risk of hidradenitis suppurativa. Turns out that, again, same thing. People who didn't smoke had much less risk than people who did smoke. But the bottom line was there is a value in patients quitting. What they did not study, what I would like to know is that if you have hidradenitis suppurativa and we're treating you, if I stop your smoking, will you get better? Will you be easier to treat? My supposition based on this data is that that is true, but that really was not part of this particular study. Another study on another skin disorder that I like, Still's disease, refractory Still's disease, a meta-analysis of JAK inhibitor use. I've talked about this in the past. I'm a big believer in JAK inhibitor use, especially for treatment of cytokine storm or macrophage activation syndrome. In this meta-analysis of 9 studies and only 35 patients, they did show, and the JAK inhibitors that were looked at were mostly tofacitinib in 17 patients, baricitinib 14 patients, ruxolitinib in 4 patients, and upadacitinib in 1. When they combined them, they were able to achieve remission with a JAK. And these are people who largely had a refractory disease. So you can imagine what they were refractory to, more than steroids, probably even biologics. But half of them were able to achieve complete remission. In the one study that they looked at with ruxolitinib, 4 patients, 100% of them had remission. A third get partial remission with a JAK, and 1/5 have no response or lose effect. So again, I think it's important to know that this is an option. But again, they probably have different indications other than being just refractory as to why they were getting a JAK inhibitor. Was it just for the fever and the rash? Was it, I don't think it was most of these were not for arthritis, okay? That would make sense, but I think we're talking about systemic disease, febrile disease, and complications of Still's like macrophage activation syndrome. Another meta-analysis this week of 40 studies, 21,000 psoriasis patients, looking at PASI 90 responses, looked at what predicts a poor response to a biologic. And in this study of psoriasis patients, not PSA, that being older, being a smoker, having a high BMI, especially a BMI of greater than 30, and prior biologic use predicted that you weren't going to do as well if you started on a biologic. And they were looking at a real, again, as I said, this is 40 studies, a variety of different biologics, all of which you're familiar with. So that's the patient who you're more likely to have problems in managing. And by the way, the amount of lowering of response, it's almost 60% when you had prior biologics, almost 40% with a high BMI, about a 20% reduction with steroids. So these are important factors in managing these patients. You may have remembered ACR 23. We talked about a new TYK2 inhibitor called TAC 279. I think it comes from the drug company Takeda. It's got a name now. It's called zasocitinib. Zazo, I kind of like that name. It's got some spark to it. It's a new TYK2 inhibitor being studied, not yet approved for use in psoriasis or psoriatic arthritis. At ACR 2023, Alan Kivitz and colleagues talked about its efficacy in PSA. And it clearly worked at the 2 highest doses. So in this study from April Armstrong in patients with just psoriasis, 259 patients with moderate severe plaque psoriasis, they either got placebo, I think it's the doses were 10 or 5 is the low dose, and then 15 and 30 milligrams. The 2 highest doses had a PASI 75 response rate of 67%, more than 2/3, versus a 18% placebo response. And again, primary endpoint on responses were at 12 weeks. So this is like other JAK inhibitors or TYK inhibitors. They work relatively quickly. This is yet another TYK2 inhibitor. There are other TYK2s that are in development. Right now we have only deucravacitinib that is in use for psoriasis and psoriatic arthritis. Looking at the drugs that we use to treat psoriasis and psoriatic arthritis and spondyloarthritis, there is a number and an interesting report this week about hepatitis B reactivation when you're using these drugs, IL-17, IL-12/23, IL-23, and JAK inhibitors. So a meta-analysis of many different studies showed that patients who have chronic hepatitis B, meaning that they are B surface antigen positive or have detectable double-stranded Hep B DNA titers, show really high rates of reinfection. So chronic HBV, the reinfection rates were like 14%. But if you had occult or resolved infection, these are B surface antigen negative, but they are B core antibody positive, that's resolved infection, they had lower rates, 4 to 5%. And that's about the rate, 2 to 4% seen with other biologics like an RA with TNF inhibitors. So the bottom line, though, is the chronic infection shouldn't be getting any of these biologics. And this is, again, B surface antigen positive patients without being on prophylaxis and without being co-managed by a hepatologist. I personally don't believe that a resolved infection with core antibody positivity only needs to be on prophylaxis, especially if they are surface antibody positive, meaning that they basically have immunity. So that's just my belief, but it's up to you. If you're comfortable with that, do as I do. If not, then get a hepatologist involved or use concomitant, etranavir or any kind of drug that would suppress reactivation. A study of a longitudinal, and I think this might be the RISE registry because it comes from Dan Solomon, but it didn't say RISE registry, but it's 32,000 RA patients followed longitudinally, shows something really interesting. And that is these 31,000 plus patients with RA followed for 148,000 patient years. So it looks like on average, 5 years of follow-up at least, shows serially higher disease activity was associated with a progressive decline in the estimated GFR. What? And that was associated with higher degrees of renal function. And they specifically looked at CKD stage 3A, which was a GFR of less than 60 cc's per minute, or a CKD 3B of less than 45 cc's per minute, divided by meter squared, whatever. Turns out that patients in high disease activity had a 27% higher risk of stage 3A, and they had almost a double or 93% added risk for 3B. Now, I wasn't aware that RA activity by itself is a risk factor for CKD. There was an abstract at EULAR that I looked at along with my colleagues. We debated making it into a big story or a big issue. We didn't think it had enough data. It might well have been this report from Solomon and colleagues. So we weren't sure about this. But there may be a story here. And of course, the decline in renal function may not be from disease activity. It might be that you're using more drugs that may have more nephrotoxic effects or renal effects like nonsteroidals. But I believe in the abstract at EULAR that we saw, it wasn't a nonsteroidal effect. Anyway, interesting and something you should be looking at. Let's end with a discussion of family history. We're all trained the same way. We're all trained to ask the question about, what's your family history? For everything, what did your mother and father die of? What did your siblings have? We lapse into crazy discussions of my aunt on my uncle's side who was married to someone and they had lupus. I don't know what the heck that means. I pay no attention to that. Immediate first degree relatives may have some bearing. This is a study done by the CDC, credibility, right? Using an NIH database called All of Us. It's called the AOU, All of Us Registry. And they asked the question, do you have a family history of arthritis, osteoporosis, or carpal tunnel syndrome? In fact, they actually asked of 7 different kinds of arthritis, including fibromyalgia, lupus, and RA, etc. And what they came up with that in patients who positively indicated they had a family history of arthritis, osteoporosis, and carpal tunnel, that the patient that was being asked the question had a 3.6 to 7.6 fold higher odds of having the same condition. What? And that they had a 0.7 lower versus twofold odds of having a different arthritis condition. The strongest association between a family history and having OA was a family history of OA and the prevalence of OA, which had an 8-fold higher rate. The same for lupus. A history of lupus was associated with a higher prevalence of lupus at an odds ratio of 6.3. So this sounds compelling, except I've been saying for years, family history, bah humbug, useless. I strongly believe that family history has utility and predictive value when there's a history of gout, spondylitis, ankylosing spondylitis, DIP in women, DIP-OA in women, and maybe I can be convinced for a marginally important effect for lupus and RA. But they came up with a lot of stuff. The problem is that it's the CDC using the NIH data set. The NIH data set is actually 450,000 people, of which they selected only 156,000 people, because only 38% of them had complete family history data. Does that represent a selection bias and a skew? I think it does. Then we compound this issue by asking those 157,000, do you have these disorders? So it's recall bias on your family history, which is notoriously wrong. Honestly, does your patient, Sally somebody who has got a history of some, arthritis condition, going to be right when she says, I think my aunt had, blank? And, rheumatoid is thrown around like it's a nickel when it really should be a manhole cover. Everybody's wrong about family history of rheumatoid because it's being diagnosed by people who don't know how to diagnose arthritis in the first place, don't know how to use lab testing. So this study is hampered, in my opinion, by all kinds of biases. And I'm still holding true to my belief that there's a limited value to family history. Now, if you're a young rheumatologist, prove me wrong. Go with what you've been taught by your mentors that ask that question, document that issue, study this, put an ACR abstract out. I'll come by and congratulate you. But I think I want to know from you, people with gray hair who are contemplating the tsunami of retirement. What do you think about this, the utility of family history? I'd be interested in your comments in the notes underneath this on the website. You can go to the website, check out these citations and more. I really like your family. I may not like your family history. We'll talk next week. Bye.